Labor and Delivery Part 2. When you're taking care of the client in labor, you're going to face some common issues. The first one is pain. It is expected and it cannot be eliminated. And some women want births that have absolutely no pain with them, and it can be difficult to deal with these women. So our job is to help manage the pain, and that can be one of the most difficult tasks that we face, and it can be a very creative task in perinatal nursing. We always look at non-pharmacological methods to help pain management, such as relaxation, hydrotherapy, breathing techniques, cutaneous stimulation, which is going to be massage or touch, imagery exercises or intradermal injections, cold position changes, walking, rocking, or the exercise ball. And of course, there's always medication. Inexperience of moms is another common issue. The basic nursing skills are needed to provide intrapartum care. It's important to develop a relationship with the client, the trust relationship. Client education should be provided prior to active labor if at all possible. And it's important for nurses to be familiar with different pain relief methods. The unpredictability of labor is an issue. Each birth is going to follow its own timetable. Each labor and birth is different, even in the same woman. Be aware that the client's mother's labor history may provide a clue as to how this woman's labor might develop. In other words, if the pregnant woman's mother had very quick labors, then you want to have that in the back of your mind that it's a possibility for this patient also. First-time mothers, the average labor and delivery length is about 19 hours. This time generally will shorten with subsequent deliveries. And if prior deliveries were rapid in a particular client, then this delivery may also be rapid. In intimacy, you need to maintain professional conduct and take cues from the parents. If they want privacy, only intervene as necessary to perform assessments. Reassure the couple that you are available as needed. Now, a lot of couples will develop a birth plan, and we try and honor these as much as possible, but parents also have to remain flexible. Advise the client as to the routines that you are required to perform per facility protocol, unless the physician orders otherwise. And in advanced labor, the presence of the nurse is often welcomed. Pain is due to the dilation and stretching of the cervix. It is also due to reduced uterine blood supply during contractions and the pressure of the fetus on pelvic structures, in addition to stretching of the vagina and the perineum. Different pharmacological pain relief methods include the caudal, the pudendal, or the saddle block. These are regional blocks, and they block pain only in the area that the medication is administered. Usually they're given just prior to delivery. Opioid analgesics such as Nubain, morphine, Stadol, Demerol, Sublamace are also very common. Narcan is administered to the mother and or the newborn if signs of central nervous system depression is noted with the opioid analgesics or epidural and spinal analgesics. Even though the baby's not supposed to get the medication from the epidural or the spinal, sometimes some of it does transfer over to the fetus. I'm going to let you review this pharmacological chart on your own. These are basically the different types or classifications of drugs, their advantages and disadvantages. This is a diagram of how the pudendal block is administered. And this is a diagram for an epidural analgesia showing where the needle is placed. With the admission process, you have to convey confidence to the mom, especially if it's a first-time mom. They're going through something that they have never experienced before and they're very nervous. Make sure that the family feels welcome by showing them around the client's room and explaining what to expect to them as well as the mother. Expectations can change with each birth, so be sure you ask and provide reassurance of normal, intense contractions while monitoring for true problems. Always, the use of touch can be comforting during the admission or labor process as long as it's appropriate. You need to make sure that you ask prior to touching, excuse me, and understand that in laboring women that the acceptance of touch may change during labor and it can actually become very irritating. Make certain that you respect different cultural values and complete any procedures needing done. If they have not come in for a pre-admission, excuse me, there's a ton of consent forms that need to be signed for anesthesia, a potential C-section delivery, blood transfusions, or HIV testing. Again, doesn't mean that these things are going to be performed, but it's better to have them signed in advance and not need them than it is to need them and have mom having received narcotic medications or dad not being available, etc. And if lab tests have not been performed, such as an H&H UA midstream for protein and glucose, and some of that stuff is usually done before you even notify the physician that the patient has arrived, depending on the status, of course, of their labor process. So we start off by assessing mom and the fetus. But you need to determine if birth is imminent before you get too far into your assessment process. You need to know how much time you've got. And you start off with that visual assessment of the client because it can determine how you go about your next assessment steps. Usually you're going to put the fetal monitor on mom and palpate the abdomen. The monitor is going to determine the fetal heart rate, contraction frequency, and duration. Of course, you can do this by palpation also, but the fetal monitor is going to give you written documentation. Palpation will help determine the fetal lie, in other words, what position the baby is inside the uterus, and the contraction intensity. And to help determine intensity of a contraction, if you push on your nose, that consistency is considered to be mild. If you push on your chin, that consistency is considered moderate. And if you push on your forehead, that consistency is strong. Now, just because mom is having moderate strength contractions or mild strength contractions per palpation doesn't mean that the contraction pain is not there. Maternal vital signs are going to help clarify if any fetal heart rate concerns are due to something going on with mom. Excuse me. In other words, if mom has a temperature, then we are going to expect an elevated fetal heart rate. Then we need to continue the maternal assessment by doing an obstetrical examination. As I mentioned in the previous lecture, the presence of ferning, this slide demonstrates that. But we're going to ask mom if she's had any leaking of vaginal fluids. We do the nitrazine paper test prior to the use of lubrication, so in other words, prior to checking the cervix for dilatation, etc., because lubrication can cause a false positive. The cervical examination, we're looking at dilatation and defacement, the position of the cervix, the consistency of the cervix, fetal presentation and position, station of the presenting part, and vaginal drainage. That vaginal drainage, as labor progresses, is going to get heavier and heavier, and it's going to be what we term as show, and it will get bloodier and bloodier. The blood comes about through the stretching and the effacement of the cervix. Little capillaries are going to begin to pop, and the closer mom gets to delivery, the heavier the show is. But it is mixed with mucus. If we have an impending birth, you're going to see mom acting very differently, and she literally gets the deer in the headlight look. She will also be behaving very differently. And here's a list of those symptoms. If birth is imminent, the nurse should never leave the client. You always need to know where the precipitous birth kit, or to shorten it, the Precept kit is, because you never know when you're going to have a delivery that comes very rapidly. Our database assessment. There are several different things that we need to be aware of as we're beginning our assessment. We need to know, why did mom come to the hospital? Has she had prenatal care before? What is her expected date of delivery? What is her GTPAL, her allergies, symptoms that she's having? When did she eat last? What is her medical surgical history? Recent illness, treatment, medications? Does she smoke or take tobacco in any other form? Drink alcohol or use illicit substances? What are her birth plans? Does she have a support person? Is there any potential for domestic violence? Then the fetal assessment is going to involve us analyzing the external fetal monitor strip. A normal fetal heart rate is going to be 110 to 160 beats per minute. We'll see a regular rhythm. If we see accelerations in the fetal heart rate baseline and the absence of decelerations from the baseline, this is also good. And the maternal assessment, once again, can give us clues as to how the fetus is actually tolerating this labor situation. So again, when we get an admission to the OB unit, there's several different things that we need to know. And as we discover this information, we need to pass it on to whoever is going to be caring for this woman during her delivery process. We also need to make sure that we have any requests of the staff or the client when we're talking to the physician. There are frequently standing orders available for the staff to follow for routine labors. We usually will obtain some IV access on mom once she reaches a certain point in her labor, because of the potential need for hydration or medications or potentially a blood transfusion. IV access is required if mom is going to have an epidural analgesia or an induction, or for an emergency C-section. A perineal prep is done just prior to the client beginning to push. The hair in the immediate area of the episiotomy, whether you expect one to be cut or not, should be removed by clipping the hair near the skin. We don't routinely shave women anymore, but if there is long vaginal hair there, then sometimes it can get in the way. And it may be done near delivery time. We do a perineal cleansing, and there's a good diagram in your book where you always clean away from the area that you want to be the most clean, although delivery of a newborn is not a sterile procedure. There's just no way it can't be, with mom unintentionally urinating as she pushes or passing a stool as she pushes. It's just not a sterile procedure, but we want things to be as clean as possible. So you always clean away from the vagina onto both upper thighs, down the perineum towards the anus, and cleaning into the symphysis pubis area. Some women will require an enema to be given. Again, this is not routinely done, but basically the idea is to help remove any obstacles to fetal descent. Again, we're going to do a fetal assessment. It's part of the assessment process, and I will provide some more detail here in the next slide. With maternal assessment, you're looking at her vital signs. You're looking at contractions. They need to be assessed through palpation or fetal monitoring. You monitor for strength, length, and frequency. You're monitoring labor progress, which is done by a vaginal examination. The cervix is going to go through several changes besides just dilating. It will dilate from 0 to 10 centimeters. It will thin from where it started to 100%, and that is really paper thin. And it will move from posterior to anterior. We might do INO, and it may not be an actual INO as much as keeping track of the last void, because urinary retention is very common in laboring women, and a full bladder can also help prevent that fetus from passing through the birth canal. It's just another obstacle. So assess the bladder for distension every couple of hours or more frequently as necessary. As the fetal head moves down into the birth canal, again, it's just very important to keep track of when mom has voided last. And response to labor. Behavioral response as labor intensifies. Monitor for nonverbal signs of pain. Not all women are going to complain or ask for something for pain. Make sure you take care of the support person, giving reassurance to them, and assessing for signs of anxiety, fear, frustration, etc. Labor support is extremely difficult. Many maternal assessments are going to help us determine if there is a situation going on with the fetus. And I've said that before, and I'll continue to say that. You always have to compare the two. So the fetal assessment. We have gotten very dependent on our external fetal monitors, as they do help us to assess fetal well-being. It is individualized per maternal fetal situation as to the frequency, as to how frequent they're applied. We do look at the A1 guidelines though, and A1 states that the active first stage of labor, the fetal monitor should be on every 15 to 30 minutes, or we are assessing the fetal heart rate that frequently. And A1 guidelines state in the active second stage that should be increased to every 5 to 15 minutes. We look at the amniotic fluid. Amniotic fluid is supposed to be clear, but it can contain bits of vernix in it, so it may have some little flecks of white in it. It's very sweet smelling. Spontaneous rupture of membranes can occur at any time during the labor process. Again, after the rupture of membranes has occurred, whether it's spontaneously or artificially, fetal heart rate needs to be monitored for at least 1 full minute following rupture. and that vaginal exam to determine potential cord prolapse unless you know for a fact that fetal head is well engaged into the pelvic outlet. Make certain that you document the time of rupture, the fetal heart rate, the fluid characteristics. We judge the amount as large amount is over 1,000 mLs and moderate is about 500 to 1,000 mLs. And of course this is just a visual gauge because you're not going to be actually measuring the amount of fluid. We also look at the fetal heart rate looking for variability. This will indicate that there is adequate oxygenation and function of the fetal autonomic nervous system. Periodic patterns in fetal heart rate are going to be described as accelerations or decelerations. Again, a normal fetal heart rate is going to be 110 to 160 beats per minute. Now there's a variety of ways that we can perform fetal monitoring. The electronic fetal monitor is where you have both of those probes strapped onto mom's abdomen. It can be continuous or intermittent. It requires that tocotransducer, which is going to measure changes in the uterine tension, and the Doppler transducer, which will provide sound waves to detect movement. And the movement that we're searching for is fetal heart rate. But it can also pick up maternal heart rate if the nurse is not skilled in placing the tocotransducer or the Doppler transducer. Maternal positioning, tissue between the transducer and the object that we're trying to measure, whether it's the uterus or fetal heart rate, the fetal lie, etc. All of those can affect the different readings, and there's other things that can affect that also. A Doppler is a handheld model that is used for intermittent auscultation, and a fetoscope is a special stethoscope that is used for intermittent auscultation. A fetal scalp electrode is going to be attached to the fetal scalp with a little piece of sharpened metal. It looks like a needle that has been coiled. It can help provide a more accurate reading. However, it is invasive, so we don't use this any more frequently than we have to, but I always encourage women in my childbirth classes that if the nurse or physician recommends it, usually there's a reason and something they're concerned about, that they need to get substantial information that can only be obtained with a scalp electrode. A normal fetal heart rate baseline, again, is going to have variability, which again will show adequate oxygenation that assists the fetus in adapting to the stresses of labor. Variability will evaluate the function of the fetal autonomic nervous system. It's the primary indicator of fetal oxygenation. This is a visual interpretation of the baseline. So basically, when we are talking about variability, we don't want to see the fetal heart rate sitting at one rate continuously. We want to see it fluctuating from usually 5 to 10 beats from what we consider to be the baseline. And I'll show you an example of this in a few slides. Absent variability is going to be undetectable amplitude range. Minimal fetal heart rate variability is going to be from undetectable to a 5 beat difference. Moderate is going to be 6 to 25 beat amplitude range, and marked is going to be 25 or above. Different factors that can affect variability will include if the fetus is asleep, narcotics or other drugs, alcohol, illicit drugs, fetal sepsis, fetal tachycardia, gestation less than 28 weeks, fetal anomalies, hypoxia, abnormalities of the CNS, heart, or both, maternal acidemia or hypoxemia. When we're looking at tracings, any acceleration is going to be normal. It's good. We like to see those. A fetal heart rate that elevates for 15 beats per minute for at least 15 seconds above the baseline is defined as an acceleration. Accelerations indicate that the fetus is tolerating labor well and has oxygen reserve. Excuse me. It may accompany fetal movement, contractions, and vaginal examinations with stimulation. Decelerations, there's 4 different types, and we'll discuss those here. Early decelerations will start with a contraction and end when the contraction ends, and it usually is a mirror picture of the contraction itself. It has a subtle onset, and what it's telling us is that there's some fetal head compression, and it's a normal vagal response of the fetus. It's benign. It's not a sign of fetal distress, and it requires no intervention beyond ongoing labor assessment and surveillance. Late decelerations are going to begin after the peak of the contraction, and they do not return to the baseline until after the contraction ends. These are abnormal, and they're telling us that there's some uteroplacental insufficiency. In other words, baby is not getting enough oxygen. It's not getting enough of what it needs. Or it can tell us that there's some fetal metabolic acidosis. Late decelerations have to be addressed. Variable decelerations occur due to cord compression or fetal head compression. It occurs at variable times, and they're not related to the contractions. They're defined as an abrupt decrease in the fetal heart rate at least 15 beats per minute and lasts 15 seconds long, and it takes less than 30 seconds to reach the nadir. In other words, the lowest depth of the deceleration. Repetitive deep variables will require intervention. Prolonged decelerations are a change of at least 15 beats per minute, and they last over 2 minutes, but less than 10 minutes in duration. If it lasts over 10 minutes, then we are considering this to be a baseline change, not a deceleration. They also require intervention. So to help you remember early and late decelerations, it's okay to be early for dinner, but don't be late. So this is a diagram of variability. You can see how from beat to beat there is some adjustment in the fetal heart rate, the amplitude, and moderate variability is good. It shows us that baby still has some reserve. It's tolerating labor extremely well. Any variability is better than no variability. This is an example of an early deceleration. If you look at the start of the contraction, the fetal heart rate is beginning to go down, and it's basically just a mirrored copy of the contraction itself. Early decelerations are not bad. Early decelerations just mean that things are probably progressing. Excuse me. This is an example of late decelerations. The deceleration of the fetal heart rate, which is up on top, goes down well after the contraction has started, and it doesn't go back to its normal rate until after the contraction has ended. Variable decelerations, if you look at where the deceleration is at its lowest, each one of these little boxes is going to be considered 10 seconds. I'm sorry. Yeah, each little box is considered 10 seconds. So if you go from where the deceleration begins to the lowest point, if it's less than 30 seconds, then that fulfills the definition of variable. Usually you see this with cord compression. Sometimes you'll see it when mom is pushing. Excuse me, this is a prolonged deceleration. You can see how the deceleration is lasting several contractions. Each one of these dark lines indicates 1 minute, so it's definitely less than 10 minutes. So abnormal and normal heart rate. We have different categories, 3 different categories. Category 1 is reassuring. Everything's normal. It's where it needs to be. We've got moderate variability. We may or may not have early decelerations. We may or may not have accelerations. It's telling us that this fetus is tolerating labor very well, and it has adequate reserves to continue tolerating labor. Category 2 is indeterminate. It is everything that is not a Category 1 or a Category 3. Examples are going to be, we have fetal bradycardia, but we still have variability. We have fetal tachycardia, minimal baseline variability. We still have some reserves there, but probably not for long. The absence of induced accelerations after stimulation, prolonged decelerations, or recurrent late decelerations, but we still have variability. Category 3 is non-reassuring, and examples are going to be a sinusoidal pattern or an absent baseline fetal heart rate variability and one of these 3 things: recurrent late decels, recurrent variable decels, or bradycardia. They require prompt evaluation and intervention, and if interventions do not help resolve the tracing, then we are to expedite delivery. And this is an example of a sinusoidal pattern. It's a sawtooth pattern. Excuse me, it's not to be mistaken for variability, because it's not. Usually a sinusoidal pattern is evident when we see the fetus starting to hemorrhage with something like a placenta abruption. In other words, it's not